Well, hello, everyone. Good Friday to you all out there in SADS Foundation land. It's great to be with you. I think we might be at podcast number or SADS Live 89, 2 years plus and counting together during this COVID-19 pandemic as a family. And for many of you, you're like family. So welcome to the family. My name's Mike Ackerman, and I'm a genetic cardiologist at the Mayo Clinic in Rochester, Minnesota, where I serve as director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and its complementary Winland Smith Rice Sudden Death Genomics Laboratory. And as you know, we're devoted to trying to get smarter about your kind of sudden cardiac death predisposing genetic heart conditions that, when identified, when diagnosed, are incredibly treatable conditions where we expect you to live and thrive. And you know that's what we've been about. And as part of the SADS Foundation, the Sudden Arrhythmia Death Syndrome Foundation, and its CEO, Alice Laura, welcome. Thank you for partnering with us. Thank you for reaching out and becoming part of the SADS Foundation family. Thank you for your gifts, your philanthropic gestures to the SADS Foundation. We hope this has met your needs every Friday, and now more recently, every other Friday as we get together. And on this special Holy Friday, Good Friday, it is good to be with you. I'm looking forward to seeing who's joining us. This month, as you know, we've been part of Brugada Syndrome Awareness Month, and one of the genetic heart conditions, much less common than long QT syndrome, but still very important, and one that we try to provide support for, that we try to help advance the science for at the SADS Foundation, is Brugada syndrome. And as part of Brugada Syndrome Awareness Month, I thought it would be great to bring a return guest. She's been with us before. She's somebody very special to me and to our field, Dr. Georgia Sarquella Brugada. Yes, Brugada as the last name. And so Erin, through her magic, here's Dr. Georgia Sarquella Brugada. Hello, Georgia.
Hello, Mike. How are you?
I'm great. I'm even better with having you join us again. So welcome back.
Thank you so much. It's a pleasure being back with you. And even though the pandemic is almost finished, let's say, it's so good to keep this type of talks so we can see each other more often.
Yeah, and I can't wait till we can see each other in person. And I think in person is, well, I know 6 weeks away, because I think we're going to be together in Sweden.
Yeah, we are. We are going to be there together.
And are you going to be coming here to the States for Heart Rhythm Society or no?
No, not unfortunately. We need to catch up with all the work we left behind during the pandemic period. And our patients need us, and we are there to work hard. So we try to reduce at maximum the number of congresses.
Yeah. Well, I know I'm counting down the days to sit at the round table with you in Geneva, Sweden, in about, it looks like about 6 weeks. So I can't wait. And we have Laura joining us from Scotland, so close. At least first letter is the same. So hi, Laura. And as we, before we bring some awareness and the spotlight on Brugada syndrome, let's put the spotlight on you, Georgia. Tell us and remind everybody a little bit about who this wonderful friend of mine is. So give us a little sketch of the life of Georgia Sarquella Brugada.
Okay, so one of the things I want to say is I'm a pediatrician, first of all, and that's important. But I think pediatric life does never finish, and that's why people like you, Mike, and myself, that even though we come from the pediatric background, I think we have the capability to go further for the rest of the family with a special heart doing that. And I'm devoted to arrhythmic syndromes, genetic cardiology, sudden death. And we are working and doing research on all those type of fields, and trying not only to look for solutions but to prevent sudden death and to treat them the best way, and to just work together during this journey.
And give me a sense, Georgia, besides being a genetic cardiologist, a genetic heart rhythm, pediatric electrophysiologist, also you have some adorable children. Life outside of work takes you what when you go home at night?
Yeah, I have two lovely girls. They are in this pre-teenage period, which can be really time-consuming, but they are beautiful, and it's true that it's a blessing having a family and having a partner. My husband, Oscar, who is part of my personal life, but also professional life as a geneticist, and of course this makes life a little bit easier because we understand each other a lot on that.
And what's it like growing up with the last name Brugada? Cerquella is not as familiar of a name, but Brugada is sort of one of those names that has garnered worldwide recognition in our field. What's that like?
Well, I think one of the points of being a pediatrician was trying to get rid of that cardiology background, but I think I like this field a lot, and I ended up here. But of course, it's pushy. Huh? It has been hard during life because probably I had to prove much more than the rest. I think I could find my spot in this world, and I adore and I'm absolutely devoted to that. And I think that people that knows me and worked with me and are next to me know that how this is much far away for than a surname. It's just part of a way of being.
Yeah. And besides the work that you do with Brugada syndrome itself, when you're not busy seeing patients and you're not busy with the girls, I adore her daughters, by the way, or with Oscar. Hello, Oscar. What are you hoping to be advancing in your own research program? Are there a few particular questions that you find yourself consumed by to try to get answers for?
Yeah, well, we have. I work in a pediatric institution which is called San Joan de Déu. This is the largest pediatric hospital in Spain. It's settled in Barcelona, and we have one of the biggest neuromuscular reference centers here. And part of our research, big part of our research, is of course cardiac channelopathies, but we have a big space for neuromuscular diseases, as we receive many patients from all over the world with very rare neuromuscular diseases, syndromes, and so on. One of the things that we've worked the most is the idea of that the heart is a muscle. So in those for those diseases, it's so important to check for the heart as well. And part of my job is to make sure that epileptologists and neuromuscular experts think about the heart when they are treating their patients. So either epilepsy and neuromuscular diseases have a spot and a role in the cardiology department, and that's been one of my fights. And I'm so proud to say that my neurologist, in my colleagues in the hospital, have learned that, and we work hand by hand to treat that as a whole.
Well, that's good news, because it's just so unbelievably frustrating to see, which we saw just last week, an incredible delay in diagnosis of CPVT, and then the next day, an incredible delay in diagnosis of long QT syndrome, both having been diagnosed as epileptics and treated with anti-epileptic medications. And so to try to create that awareness in the neurology community. So good on you for achieving that, because it seems like we're not doing very good overall in getting sort of a healthy dose of respect that the heart could be the reason to blame for that auditory triggered generalized seizure.
Mhm. For sure. I think that it's a hard work, like to treat, to go back case by case that has presented as a sudden death, that go back to reports, and in a friendly way to sit down with the neurologist and say, okay, what could we have done differently to avoid this unhappy and sad end?
Yeah.
So that has been a hard work for a lot of years. It's been 11 years I have been in my institution now, and it's been a very slow but firm work of going from the heart, once again going from the heart, and treating this big problem from a very humble position, but to make sure that everybody thinks of the heart. And that's so, I'm so happy to have reached to this point now.
Yeah.
It's amazing.
You know, you and your family and the Pedro and Joseph, give them a hello from me. Ramona, hello if the family is getting together for this blessed weekend. But as you all think about or reminisce around the table about the beginnings of Brugada syndrome when they described it to where we are now, what does the Brugada family in general, or Georgia, you specifically, think that have been the three maybe biggest advances that have occurred with respect to Brugada syndrome over these last 2+ decades?
I think one of the most important ones is the fact of the family screening. And that's important. Even though it's logical because Brugada is a genetic disorder, it's true that the fact of thinking, not just with your patient, but opening broad a view of the spectrum of the family, it's very important. And it's, even though it's I think it's a very good thing that has happened, it's not always like this.
Yeah.
And Mike, that this is very important. So to conceive the family, this is a family problem, and that's very important. The second thing is the having reached the awareness of the medical community and the health care professionals about subtle ECG changes that make you think about Brugada. This is a good thing. It can be a bad thing as well, because you know that so many patients carry a diagnostic of Brugada just because of an incomplete bundle branch block. Huh? But of course, that anyone doing an ECG for whatever reason is it's well, can or just able to just look at this ECG, say, well, I don't really know, but I will send this patient to an expert for that. That's very important. I think even though it's not like a scientifically big thing, but I think for patients it's huge, because not, thanks God, not all the ECGs performed to people are read by an expert for channelopathies. Most of them are not. So it's very important that people just think about Brugada when they see an ECG.
Yeah.
And finally, I think the third big thing is the ablation, no? As considering one of the treatments for something which of course should be only offered for those patients which are unsolved patients that go bad, and they are not going okay, even though they are protected with an ICD and they are like optimized for quinidine or whatever, they still have a bad quality of life because of arrhythmias. Other things have to be tried, and ablation has been one of those. But of course, we have to be careful once again with that, because we don't know the long term of that.
Yeah.
And we know that Brugada is a channelopathy of the whole heart, and we are only treating one little spot for that. And that's important. But at least there is something that for those struggling cases, for those difficult cases that put the patient at very high risk, at least there's something we can offer additionally to them.
Yeah, Georgia, those are three great advances in our SADS community. They bring incredible questions to the table, and they fit really nicely in with those three advances. So let me ask you, in terms of, thinking about it as a family disease and family screening, one of the members on Instagram is asking, what routine testing would we recommend for a child of a parent who's been diagnosed with Brugada syndrome and for a sibling who apparently died from a sudden cardiac arrhythmia? We don't know whether, at least from the question, whether the sibling was a Brugada death or not, but maybe just when a parent has been diagnosed with Brugada syndrome, what say you for the children of that parent?
Okay, no, normally that what there are two types of families. The ones that we have a genetic positive test, which then it's easy. You check if the child is positive or negative. That's it. And then what it happens in the most of the cases that you don't have a genetic test where you can just decide if the patient has or not has Brugada. So if this is the case, so daddy has Brugada, genetic test came negative for Brugada. So what do we do with the children is we do an yearly ECG, a basal ECG, with special positions on the upper right leg positions at the basal situation. And we give them a note, a letter, saying it would be good to have an ECG during febrile episode, during fever, because we know that in children, mainly in children, but also in adults, fever can be one something that could unmask the Brugada pattern on the ECG. And that's what we do before puberty. And that's important. If everything comes normal, that's what we do every single year, and that's it. After puberty, we offered the patients Ashmelin test, a provocative drug test to know if we can unmask the pattern with this with the test. And if it comes negative after puberty, we can tell the family that we have given the, let's say, worst scenario for that patient, and it's not changing the ECG. So we are much confident that this patient has no Brugada.
Yeah. And then you made a comment about the potential therapeutic role of ablation, and you had mentioned in passing Quinidine. Alexa is asking us whether Quinidine is typically prescribed without a beta blocker question. Her EP team is not familiar with the drug. So maybe some comments about sort of one of our dinosaur drugs, Quinidine, that's been around forever and is almost never used anymore except for some patients with Brugada syndrome. How have you found that drug? How do you use it? Do you use it without a beta blocker?
Yeah, it depends. Normally, I offer Quinidine we don't have Quinidine in Spain, so we have to import it from Germany. That's not a problem for the patient. It's a problem for me. I have to fill in many papers. But once this is done, it's not a problem for the patient. Besides what it's normally said about secondary effects of Quinidine, we don't see that many in children, and that's true. But I offer them for those children that having Brugada, they have kind of arrhythmias that then I am blocked to use other drugs that could be could worsen the Brugada patient, and Quinidine is something that to stabilize all those arrhythmias. In some of them, I add beta blockers, nadolol, and in some I don't need to add nadolol. Sometimes I give it alone, but we only give it to patients having arrhythmias. I know there are other centers that give it as a prevention for patients having a spontaneous type 1 pattern, Brugada pattern. Even though they have never had arrhythmias, they give it just like that. Or even some groups give it as an alternative to ICD implantation, before ICD implantation, in patients having had arrhythmias, being Brugada.
And speaking of the Brugada arrhythmias, Jennifer is wondering whether we can talk about specifically what are the Brugada symptoms. So how do our patients know that they might have had a Brugada triggered arrhythmia. And I think this is I think Jennifer's asking such a great question, because I know you and I have had patients say, you know, I got up quickly and I got lightheaded. Was that my Brugada? And we say, no, that wasn't your Brugada. Or I felt my heart, I have a pulse heart monitor and my heart rate is running in the 50s. Is that my Brugada? And we say, no, that's not your Brugada. So what symptom would they tell you that would make you say that, on the other hand, might have been because of your Brugada substrate?
Mainly, I have to say that symptom number one in patients with Brugada is no symptoms. And that's important. Most of the patients, the vast majority of the patients, will never have experienced any type of symptoms because they would be at a very low risk of having them. That's very important. I mean, and that's something we are obliged to convince our patients about that. But of course, to convince about that, we need to share with them which are the symptoms. And mainly they are sudden syncope, like you just lost conscious, really lost conscious. It's not this type of I wake up and I have dizziness in my head and I can just go there and fall down like a princess. Okay, that normally it's not related to Brugada. Second thing is funny palpitations, like having a horse inside of your heart. We know that Brugada patients have two types of arrhythmias. The dangerous ones are the ones from the lower chambers of the heart, which are the ventricles, and they sometimes give you dizziness and feel like funny feeling. But it's very typical for Brugada patients. They have other type of arrhythmias from the upper chambers, the atrium, which are supraventricular tachycardias or flutter or atrial fibrillations, which they don't put you at risk of dying for those arrhythmias, but maybe they can be the first symptom of a Brugada syndrome, and that's important. And the other thing, it's something you will not, as a patient, you will not feel, but your partner sleeping next to you might feel. Is like having this kind of what we call agonic respiratory noises during night. And I don't know the English term for that, but when you kind of die while snoring and breathing during the night, that wakes your partner up in the middle of the night, and that can be a symptom of arrhythmias during the sleep in Brugada patients.
Thanks a lot for that, Georgia. And on that last one, like you said, the agonal breathing, where you really are fearful that the partner just died. How is that different from the snoring husband who has obstructive sleep apnea, who does that every single night? Because obviously a Brugada episode isn't happening every night. So how do we make sure that the spouse isn't, because often it's the man, that we don't have the wife thinking every time they hear their husband snoring that the Brugada is doing its thing. Is there something that's particularly different when we tell them or ask them about agonal breathing?
Well, they cannot wake the partner up. That's something that you move the patient and it does not stop snoring, let's say. And and probably, whoops, I have my Siri answering to me, which is nice. and it's snoring, and if it snores, you just touch your partner, it will change position and will stop snoring or no, but it will change position by him or herself. If it's agonal breathing, for nocturnal agonal breathing, probably the patient will never change position because he's having an arrhythmia by that time.
Yeah. I think that's very helpful and very important, because we know a lot of them are getting unnecessarily worried when they read about this thing, and then they say, well, my husband does that every single night. And was no, not doing that. You had mentioned that the most common symptom is no symptom. Let's talk about that a little bit, because Emily's asking a question saying that and I assume this is a young adult woman, that she's asymptomatic, has a type 1 Brugada, no defibrillator implanted, thankfully. Good job. But she's still worried. And she said, what percentage of people's first symptom is the funeral, is the tragedy of sudden cardiac death? And she finds herself really anxious not having an ICD.
Well, ICD has good things, but it implies bad things as well. Not only the complications for the device itself, but also the uncomfortable, inappropriate shocks. And that's very important. For a woman with an spontaneous type 1 ECG who takes care of the drugs that she should not take because of her Brugada, and if she has had an EP study which is negative, and I know this can be of a lot of controversy, but that's what we do. That spontaneous type 1 ECG, we perform EP study, and it's negative, we can be pretty sure that she's going to be okay. And that's very important. Once this is okay, it's okay. I think life goes on, and there are two ways of living life: thinking that you are gonna die every day, or thinking that you are gonna wake up tomorrow morning. So that's it's very it looks like very banal, but I think it's very deep, and that's something we need to share with our patients, that most of the time it's going to be okay, and we have to go to sleep thinking that sun is going to be there tomorrow, and that's important.
Yeah, very good. Ryan's question fits in too with you. We said that you had mentioned that if the genetic test is positive, then it's kind of easy to figure out who does, who doesn't have it, and then focus on those who inherited the genetic marker. But Ryan's wondering, in his case, 29 years old, male, no family history, no symptoms, no issues, ECG every year, no concern, but is told that he has a VUS on a genetic test that hasn't been determined. And it sounds like they're not quite sure how to navigate his status. A little bit about the complexity of unraveling a VUS in that kind of scenario, where it sounds like without the genetic test result, you and I probably would have dismissed this person a long time ago.
Yeah. Well, it's nowadays that we perform genetic tests so easily. It's very common that we have some VUSs in whatever gene that makes we think a lot of things. But if the patient has normal ECG, has never had anything, and we are pretty sure that this VUS never has been published as related with Brugada, I would really say, okay, just it's okay. In some cases where you have some doubts, Ashmelin test or provocative drug test can be used to rule out, if we give you something that you should not take, what happens? And if it happens nothing, even we can dismiss this patient. So that's important.
Yeah. You know, one of the things you had said that you would kind of like to see what those ECG pattern might look like in those leads in the setting of fever, and having the child or the parents bring them in to get a fever ECG. Thinking about the last 2 years of the SARS-CoV-2 pandemic and that virus that causes COVID-19, which produces fever, we've been kind of pleased, and I wouldn't say surprised, because I think it just is a testimony to how much reserve the human body has, that we just haven't really seen a pandemic of Brugada triggered events from either the virus producing fever or the vaccine causing a febrile reaction. Has that been your impression too, that yes, there's been a few events? I think maybe one of your relatives even published a fever response ECG in the setting of COVID-19, but very anecdotal, as in almost never. And that's kind of been some good news. Wouldn't you say that we should keep getting vaccinated if we're supposed to?
Yeah,
If we do get a fever after the vaccine, or if we get the virus itself, take your fever lowering medicine, but don't be afraid.
that's it. I mean, no need to be admitted in a hospital just for that fever or whatever fever, and make sure you lower your fever down, and that's it. That's very important, I think. And I think that they have had less fever than normally our patients because of the masks and for washing hands. That even though the pandemic is almost finished, just please keep washing your hands as much as possible as well.
Yeah. And fast finger question and response on Cindy's nightmares. She said that she's heard that nightmares or night terrors is a Brugada syndrome. What say you? Is this true?
No, no, I mean, not as far as I know, and it's difficult for me. Look, nightmares are good because it's adrenaline, and adrenaline it's good for Brugada, so it's okay.
Yeah. And Kelly is asking about autonomic dysfunction and how that might relate to Brugada syndrome. Do you find much of a connection with your patients with Brugada syndrome where you have no doubt that they have Brugada syndrome, that their autonomic function is any different than any of your other patients?
Not really, but the big ones, those 10 big names that we all have in our heads, in our brains, they are under medication, so you never know what's going on when they have dizziness or low blood pressure, if it's because of the drugs they are taking or because they have um, maybe a different life, huh? But not especially from my side. What about you, Mike? Do you have patients?
Not really. I mean, I certainly have had an impression, right, of some maybe, well, in long QT syndrome, I remember very early on, we used to do tilt table testing prior to doing epinephrine infusion in long QT. And it was like we had 18 out of 20 patients in a row with long QT syndrome having a positive tilt table study. So I think long QT patients have an increased tendency for the vasovagal normal faint, which is really important to dissect out because it just means that long QT patients and Brugada patients too, they have the right to have ordinary fainting. And so just because they fainted doesn't mean that that's an immediate line to the defibrillator, especially if they met with you afterwards and you said, wait a second, I don't even think that that was your Brugada that made you faint. That was called you're a normal teenager and you fainted.
Yeah, that's it. That's the big problem. Huh? That's why in some patients we implant subcutaneous halter because we don't want one of our Brugada patients to have an ICD implanted just because they had this vasovagal syndrome episode, and just because you are Brugada, you need to everything has to be related to the heart. No, normally almost nothing will be related to the heart, but it's difficult to separate both situations.
Yeah.
Yeah.
The questions that have come in have been so good, but I see we've almost consumed our time together, and the girls probably are getting close to. I don't remember if the book was Goldalicious that somebody might have gotten them.
Pinkalicious.
And whether it's reading time or maybe they're already grown up past.
They are with Harry Potter. They are with Harry Potter.
Yeah, yeah. But as we go forward, we've done a bit of the past and the present. Last 5 minutes on the future. What still frustrates you the most about Brugada syndrome, or you still find as the three big unknowns or the three scenarios that you're not satisfied with how we're currently doing it? What are some of those sources of Brugada frustration for Dr. Brugada?
Well, first one, it's when I hear cardiologists saying, "Oh, to a man having Brugada, you don't need to check your sister and your children because it's a woman and children, and Brugada only affects men at their 40s." Okay, that's my big frustration. I get very upset with that, and I say big words. Okay, even though we've done so many presentations, so many conferences about that, we still hear that message, and that's not true.
Mhm.
The second thing is that the opposite situation, those doctors telling the sorry, there is noise here. Those doctors trying to fear those patients just because they have Brugada syndrome.
Mhm.
I hate that type of professionals that want to be like upper in the categories just because they fear their patients. And I think we have to be realistic, and real life is that they go really well, and except for little exceptions, and that's important. Having Brugada, I always say, if I have to choose a disease for my kids nowadays, it's Brugada, because it's something that you don't need to take drugs. You can do normal life, exercise, whatever activity, and most of the cases, everything is going to be okay. So that's the truth.
You do take cocaine away from those though, right?
Yes, cocaine, and I tell them
I
not
couldn't
to
resist,
drunk.
I couldn't resist that you
Yeah,
would not let your children with Brugada do cocaine.
that's it. For many other reasons, that Brugada, but and finally, my big frustration, and I'm sure it's the same for you, are for those children presenting with early Brugada but high risk situations, that they are not only, they might not look like Brugada at the beginning, but they develop Brugada. So I think we are in front of a whole different disease, which is not Brugada. This is not the adult Brugada we see. It's another type of disease which goes with sodium channelopathy. So 95% of them are sodium channel positive. So it's not the same disease, that they evolve. They have a different prognosis. It's a whole channelopathy of the whole heart, not just the right ventricle outflow tract. It's just from the atrium, from both ventricles, and it's a whole different story. And that's a frustration, because there are so few cases that we don't really know. And every time we get one of those as being reference center from our countries, it's kind of a big battle, because you don't know what to do. You kind of just live with that and try. And that's the real truth. That's a frustration, but of course we like this type of frustrations, because those are the patients that just make our brain go crazy thinking, and we
Yeah.
love.
Well, I have really enjoyed our time together, Georgia, and thanks for taking the time out on your Good Friday evening. And I can't wait to have you back. Can't wait to see you in 6 weeks in Geneva. And for you and your girls and Oscar, I just give you and your family Easter blessings. It's a very special weekend upon us for those of us who embrace Christianity and the hope that we have for eternal life because of a risen Savior. So, Easter blessings to you, Georgia. Best to you and your family. And thanks for joining me. And for all of you out there, I think we're getting together again in 2 weeks, or maybe I'm not sure on the time. You'll just have to check things out, because we do have Heart Rhythm Society 2 weeks from today to hear about the latest in the advances of a variety of genetic heart conditions in San Francisco. So we'll be together when we're together. And in the meantime, be well, be safe, do not fear. For those of you who have Brugada syndrome, like Georgia said, wake up, go to bed tonight knowing that you are going to wake up tomorrow and have a rich live day tomorrow, and do that each and every day. So best to everybody, and we'll see you the next time.
Bye-bye. Thank
Bye-bye.
you.